Keep in mind that in order to make this diagnosis, you first of all have to know that they had a DVT. These should be new complaints. So you heard Jerry O'Sullivan sort of talking about that critical question, how long has your leg been bothering you? If there are prior symptoms, that they're worse, and that there's no alternative diagnosis. So let's kind of go through this. The clinical history is really important. So the baseline leg symptoms, what's happened since then, if there's ever been a history of DVT, infection, surgery, or other kinds of issues. And then your examination is absolutely pivotal, and you have to do this. You cannot rely on someone else to tee up a patient for you, make a diagnosis, and have you walk in the room to intervene. So you want to check the pulses, make sure that you do a full vascular exam, look at the skin, the venous system, measure the leg, and I really encourage you to take photographs. We're very fortunate that we have an electronic medical record that tortures us, but the one good thing about it, it's easy to put pictures into the chart so you can document over time. And this is a patient who had obvious post-thrombotic findings in the skin and remarkable sort of change over time. The photographs allow us to identify it. So how do we image these patients or work them up? There is no test for post-thrombotic syndrome, so you cannot order a specific imaging study or other physiologic exam that will say yes, no, this post-thrombotic syndrome. What you're doing is you're evaluating the venous system and the functionality of the venous system to help you make your diagnosis. So ultrasound is key, and I really encourage you to do the ultrasound yourself. Take that probe, look at the patient. It's a great opportunity to actually do the interview and explain to the patient what you're seeing at the time of the evaluation, as well as make it physiologic as well as a sort of clinical diagnosis. MR and CT are very important, at least in our practice. We're always trying to evaluate the central system, the central veins. As you heard earlier, and when Jerry O'Sullivan's talked, you just don't want to get into a situation where you're getting involved in intervention and discover there's all sorts of central problems that you weren't really aware of. We rarely use MRV or CTV. This is a patient who used MR venogram prior to treatment of all those superficial collaterals, veins that were bothering the patient. I wanted to confirm that there was actually adequate drainage through the previously occluded deep system, and you can see the venous, the venogram that correlates with this. But this does not make the diagnosis of post-thrombotic syndrome. It's really just allowing us to help us plan our treatment. And venography is critical in some patients, and you may need IVUS and even pressures. So there are objective testing schemas out there. Air plethysmography is used for reflux. So again, this is not post-thrombotic syndrome testing, but it tells you is there reflux, the emptying capacity of the calf pump, how much residual volume there is after exercise, and also ambulatory venous pressures. Are there elevated venous pressures at the end of ambulation, indicating sort of a poor ability to evacuate blood out of the calf? But again, these are not diagnoses for post-thrombotic syndrome. They just tell you whether or not there is reflux. One of the most important things you'll do is to look for the confounding conditions. And I just have a list of them here. You will get a lot of patients with swollen legs, who everyone assumes is post-thrombotic syndrome, and maybe they have some skin changes, maybe they have chronic venous insufficiency, or they may even have had a DVT, but they have other problems. They have poorly controlled congestive heart failure. They have sort of low albumin, and they have edema because of that. So you have to really kind of work through all these causes. Lymphedema is a very common co-founder if there's been a history of leg infection, swelling after this, or leg injury and swelling. This could be lymphedema. And this is just one of our patients who we sent in with this horrible looking ulcer and had absolutely no venous disease. And we worked this patient up very carefully and still couldn't figure this out. It's a diabetic patient. It's probably related to diabetes. So how do you describe these patients? And this is really, I think, one of the major sort of sources of confusion and one of the major facilitators of manipulation of results in order to get the outcome that you want to portray, because these are relatively sort of indiscriminate systems. So there's a whole group of them. The two that we're going to really focus on are the LALTA and the CEAP score, because those are most common. The venous clinical severity score is often used, but it tracks pretty close to the LALTA. So let's talk about the LALTA. This was really a pivotal piece of the ATTRACT trial. And one of the reasons that the ATTRACT trial had results that for many people felt were a little bit disappointing. this is specific to post-thrombotic syndrome, so you can't really apply it to somebody who just has reflux disease, although you'll actually see it used that way. And it really should only be used 3 to 6 months after the initial diagnosis of DVT, although you need a baseline. So this is sort of a conundrum here, because you want to know what the baseline was in order to understand whether you have a new problem. There are 11 items. They're scored on a 0 to 3 scale, but they're relatively subjective. Very few of these are things that you can actually measure, and many of these require the patient to sort of give you an answer, a specific answer, and I'll just sort of show you a patient who this becomes difficult. And you can go actually download from MD-Calc and put this on your computer, and you can just calculate this on your own. So this is for the scoring of this sign, and this is actually a nice attempt by Susan Kahn to give a visual representation. So how do you really tell people how to score edema? This would allow you to do that all the way through the skin changes. So this is a clinical application. This is a 44-year-old male who had a DVT in high school, so he's had leg problems for over 20 years. He has swelling and heaviness when he does work. He actually presents because he has these cross-pubic pelvic collaterals that are now making it hard for him to close his utility belt. He is works in a prison as a guard. He has a lot of varicosities, but no pain, no ulceration. This is a guy who just gets up every day and does his thing, and so he doesn't really have a lot of pain, although at the end of the day, his leg is heavy. These are the images. So if you score him, he really has no pain. He's not complaining of cramps. He gets heaviness after he's been out, but he will tell you, well, what do you mean? I mean, at a normal day, heaviness at the end of an extensive day. He likes to hike, so we sort of have to pick a score. Is some edema, some hyperpigmentation, some redness, and some venous ectasia. So he ends up with a moderate score of 6, which is really a pretty low score, but at least remember, a score of less than 5 means you have no post-thrombotic syndrome. And that there are many patients who will have absolutely definitive post-thrombotic findings, but if they have a score less than 5, they will not be able to be listed as having post-thrombotic syndrome. But he's very subjective. This is someone who minimizes all of his symptoms. There are other patients that might have had double or treble of these symptoms that this patient presented with. This also doesn't distinguish etiology, so whether there's reflux in there or thrombosis, the Volta will not distinguish that. And just keep in mind, it's derived from European patients, primarily Caucasian group. So patients who have different kind of skin tones or skin qualities may not score the same way. This has actually not been examined at all with Volta. So let's look at the SEEP score, the CEAP. This came out of a progressively more complex classification system out of a multidisciplinary group, first in 1993, and the most latest revision is 2020. There are 4 elements, but the one that is probably most useful, that most of us use, is the clinical, the C portion, and this is the sort of more refined C, which allows you to break down the C2 to have recurrent varicose veins, which is very helpful, and then there's break out the C4s. This is the etiology, which is a little more complicated, but can be useful. This is anatomy, very complicated. I am not going to spend time in my clinic trying to figure this out. And then pathology, this is something I'm just going to note. So this patient, the same patient, we're going to do his scoring again. His ultrasound shows reflux in the superficial system, occlusion in the deep. This is his occluded iliac veins. And so this is his formal CEAP score, which to me is not very useful, but what it really is a C4 with reflux in the superficial system and chronic DVT in the deep. Keep in mind that neither of these scores account for venous claudication, which is a very common symptom in these patients, and neither of these address exercise-induced intolerance due to venous occlusion, which is something we've seen in patients in whom we recanalize IVC and iliac veins. And actually their exercise intolerance improves, and you can demonstrate this quantitatively. So in summary, you can't make a diagnosis of post-thrombotic syndrome without a prior diagnosis of DVT, and Volta in particular can be applied to both. There's a lot of overlap with other conditions, particularly primary reflux. Ultrasound is your primary imaging modality. You should do it, and there's no real objective test for this. Keep in mind the limitations of the scoring systems. And longitudinal assessment is really critical in the management of these patients. Thank you.
12 to approve this